സ്വർഗസ്ഥ പിതാവാം ദൈവമേ, ഈ വർഷത്തെ 4-ാമത്തെ വ്യാഴാഴ്ചയ്ക്കായി നന്ദി സ്തോത്രം അർപ്പിക്കുന്നു. കഴിഞ്ഞ ആഴ്ചകളെല്ലാം ദൈവം ഞങ്ങളെ നടത്തി പുതിയ പുതിയ കാര്യങ്ങൾ ചെയ്തെടുക്കുവാൻ ദൈവം ഞങ്ങളെ ഉപയോഗിച്ചു. ഇന്നും ഈ നടക്കുന്നതായിട്ടുള്ള എല്ലാ കാര്യങ്ങളും ഡിസ്കഷനും പ്രസൻറ്റേഷനും എല്ലാം ഞങ്ങളുടെ ഹോസ്പിറ്റലിനും മറ്റുള്ളവർക്കും ഞങ്ങളുടെ ദേശത്തിനും ഒക്കെ ഒരു അനുഗ്രഹമാക്കി തീർക്കുവാൻ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. വന്നു ചേർന്നിരിക്കുന്ന എല്ലാവരെയും അനുഗ്രഹിച്ചാട്ട് പ്രത്യേകിച്ച് ഈ പ്രസൻറ്റേഷൻ ലീഡ് ചെയ്യുന്ന ഓരോരുത്തരെയും അവിടുത്തെ തിരുസനിൽ ഏൽപ്പിച്ച് പ്രാർത്ഥിക്കുന്നു. അവർ പ്രിപ്പയർ ചെയ്ത് വന്ന കാര്യങ്ങളൊക്കെ നന്നായി അവതരിപ്പിക്കുവാൻ തക്ക കഴിവും പ്രാപ്തിയും അവർക്ക് കൊടുക്കണമേ. ഒരു പ്രാവശ്യം കൂടെ അങ്ങ് ഞങ്ങളുടെ ഹോസ്പിറ്റലിനെയും മെഡിക്കൽ കോളേജിനെയും ഇത്രത്തോളം അനുഗ്രഹിച്ച് ദൈവത്തിന് നന്ദിയും സ്തോത്രം അർപ്പിച്ചുകൊണ്ട് ഇന്നത്തെ ഈ പ്രോഗ്രാമും അവിടുത്തെ കരങ്ങളിലേക്ക് ഏൽപ്പിക്കട്ടെ. പ്രാർത്ഥന ഘട്ടത്തിനായി സ്തോത്രം യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Welcome to another interesting quest. Today we have 3 case presentations. Case Mastery, Sharing Clinical Pearls and Insights. The first case will be presented by Dr. Betty Verghese and moderated by Dr. Mohan Verghese, Professor Dr. Mohan Verghese. The second case will be presented by Professor Kurula Chako and moderated by Professor Patsy Verghese, and the third case will be presented by Dr. Bobby and moderated by Dr. Akash. So I invite Dr. Betty to present the first case. Each presentation will be for 7 minutes and moderation for 3 minutes. Please hold the time.
So good morning, one and all. I'm Dr. Betty Verghese, PG resident in the Department of General Medicine. So today, I'll be talking about a very common clinical scenario which we as clinicians may face no matter which corner of the country we might be practicing, for that matter, no matter which corner of the world that we might be practicing. So, and also, not just about the case, I'll be talking a little bit more about an age-old practice of sample collection that was practiced in this case, which we implemented in this case, and it proved to be comparable to current conventional and advanced techniques which helped us in the diagnosis. So without wasting any more time, I'll dive into the case. So I'm presenting the case of Mr. X, a 78-year-old gentleman. He presented with chief complaints of fever since 3 months and cough since 3 months. He was apparently all right 3 months ago when he developed fever, which was intermittent type, low-grade fever with evening rise of temperature associated with chills and rigors, and it was persisting for the last 3 months. He also complained of cough since 3 months. The cough was productive in nature and scanty with white-colored expectoration. He also gave a history of weight loss of around 7 to 8 kgs over the past 8 months. So he's a known case of hypothyroidism and BPH. So on examination, he was conscious-oriented. He looked emaciated. His BMI was 16.9 kg per meter square. His heart rate was 80 per minute. BP was 100 by 50 millimeters of mercury. Respiratory rate was 18 per minute, and his oxygen saturation was 98% in room air. His systemic examination, in the respiratory system examination, trachea was noted to be deviated to the right. There was bilateral wheeze and crackles. Other systemic examination was quite unremarkable. So, moving on to the course in the hospital. So we admitted, after a thorough history clinical examination, we admitted the patient under General Medicine Unit 4 in the isolation ward. So as the routine, we sent all the routine investigations. His complete blood counts was sent. His HB was 11.2 gram per deciliter. His total counts were 7,400 per microliters. And his platelets were around 2.76 lakhs per microliters. Then his RFT, his LFT were all within normal limits. All sputum cultures, blood cultures, all of these routines were sent, which was quite normal. His ESR was 99, CRP was elevated. And so as this patient, as you can see from the history, we had, he was definitely a case, a high suspect for tuberculosis. We sent his sputum AFB, a spot sputum AFB was sent on 9th, which was negative. And also the following early morning samples on 10th and 11th was sent, which was also found to be negative. On 12th of December 2024, we planned for a bronchoscopy, and after the bronchoscopy, all the samples were sent. TB-PCR of the sputum sample and the bronchoalveolar lavage were all negative. So, radiological investigations were done. As you can see, the chest X-ray had bilateral confluent infiltrates, left more than right and left CP ankle blunting. And also HRCT chest had multiple confluent areas of consolidation in bilateral lung. So, at this point, from the history, examination, the reports, we can, I'm not diving into the diagnostic algorithm, we can place the patient, we can place him in smear negative, but chest X-ray highly suggestive of TB. So at this point, what do? We obviously we'll wait for all the reports, including the CBNAT, or if a very resource-limited setting, we might probably think of starting him on ATT. So, as we were waiting for the reports, we decided, under the instruction of Dr. Mohan Varghese sir, we decided to send a 24-hour sputum sample, which was initiated. The collection was initiated on 14th, and the sample was sent on 15th for AFB staining. And this sample turned out to be positive, and the patient was started on ATT. So, what difference does this make? As we all know, multiple samples are obtained to increase the diagnostic yield for sputum smear microscopy. It is likely to be positive. That is, the sputum smear microscopy is likely to be positive if the concentration of the acid-fast Mycobacterium tuberculous bacilli exceeds 10,000 per ml of sputum. Recent evidence suggests 2 samples obtained over a 24-hour period has the same sensitivity, that is 64%, and specificity, 98%, compared to standard collection over multiple days. So a little bit about the diagnostic tests. First, and its sensitivity and specificity. One is liquid culture. So that is the gold standard in diagnosis. That is, it's got 100% sensitivity and specificity. Conventional sputum smear microscopy. It has a sensitivity of 61% and a specificity of 98%. GeneXpert has a sensitivity of 92% and a specificity of 99%, and clinical diagnosis has a sensitivity of 24% and a specificity of 94%. So, there was a study that was published in the Lancet Global Health in 2017, wherein it was noted that tuberculosis diagnosis was substantially increased by pooled collection and comparable to new expensive laboratory tests. And the pooled sputum collection tended to have higher odds of a positive microscopy result than did early morning sputum sample collection. So this is also, this is a graph which is borrowed from the same journal, wherein you can see this shows the number of samples. It shows around 76% positivity in pooled samples and 64% of positivity in the spot samples, and also the color denotes the grade of the microscopy result. So high grade was more seen with the pooled sample collection. So not just the better quality of the sputum, it also saves time. Early diagnosis means early treatment. It also saves the need to go ahead with advanced methods of diagnosis, which is inaccessible across many regions. So before I conclude, I would like to say that alongside the development of new diagnostic techniques, it is also important that increased attention and resources are invested into studying how sputum is collected as well. Thank you.
Thank you, Betty, for the nice presentation. This is a time-old practice we all senior doctors used to do earlier days, but it is abandoned because of the new techniques have come across for the diagnostic scenario, and it is more, sensitivity is more. But here the challenges are very challenging. We know that by looking at the patient, anyone can diagnose a tuberculosis and history and but ultimately I decided personally, we used to do that in the olden days collection, 24 hours collection. We started doing it in this particular patient tend to be positive, along with the CBNAT we send along with the same sputum. The reason for the positivity, I conclude like this. This is because of the concentration per ml may be higher because to detection of the Megabacterium per ml should be more than 10,000. Previously it was 20,000 when we were studying. Now that changed to 10,000, 5 to 10,000. So that may be the reason for the positivity. And this gives an insight that the time-old practice is not bad or inferior to the current diagnosis. So it can be applied to any rural areas of any part of this, our own limited resources, countries. Thank you.
I accept that 24-hour sample, the volume of the sample will be more. But how we do an AFB smear is only taking one part of it. So practically, it is very difficult to collect all the 24-hour sample in a single container. Okay, multiple sample collection will be better rather than collecting it in a single container. So then you can actually do separately AFB staining also. So unless we do such a study, we cannot say that this 24-hour sample is ideal than what is presently practiced. So we have to do more cases like this to prove whether it is going to be helpful or not. And actually 24-hour sample is not at all requested in any of the TB cultures or anything. Only urine, early morning, entire sample they say. Otherwise, the quality of the sample which is collected is more important than the amount of the sample.
Right, but the thing is, here the international recommendation is like this, previously it was daily collection of the sputum for 3 days, then it turned to be 2 days. Now recent recommendation like advances saying that the 2 sample collection the same day. So diagnostic yield may not be good enough to, because of the amount of bacilli remain low sometimes because the collection may be mucoid. I think Dr. Luke Matthew can highlight something regarding it because he is dealing with a lot of pulmonary cases.
Thank you very much. What my concern here is, Mohan, as you said, it's 10,000 bacilli per ml. It is that which is important, not the quantity. The second one is, what my concern here is the PCR was negative. It should have been positive with a bronchoscopy. So the question is, what is our pickup? That is where we have to concentrate in this particular situation, as opposed to the quantity of sputum, the quality of our analysis, which we have to revisit because we have had doubts time and again regarding the PCR reports that have come when sputums have been positive, PCR have been negative. So I think that's where the crux of the problem in this situation lies. Thank you.
Good morning. Just to add to that point, I have done the bronchoscopy for that patient, and I was actually following up that patient also. And what I have seen is that the 24-hour sputum sample got acid-fast bacilli, which is slender and long, not like a usual bacilli. So the microbiologists actually have a doubt whether it is nocardia or AFB. So they were also actually not reporting the case for more investigations. And finally, the CB-NAT from BAL was positive, and it is not low or very low. It is moderate amount of bacilli there. So I don't know what happened with the TB DNA PCR, because the CB-NAT is positive, but the TB DNA PCR doesn't give the report. So there is something happened. And actually I have 3 cases in the last 6 months where the CB-NAT is positive and TB DNA PCR is negative. I actually have that. I was actually collecting that data.
Of the collection of the sputum is more important that along with the amount, because previously we used to centrifuge and look into the sputum samples olden days. Now the quality of collection is more important. That is important than 24 hours collection. 24 hours can be implemented rarely. It is not practiced anywhere. But I just highlighted our difficulties and ultimately resulted in a positive outcome.
What we are doing here is TrueNet, not CB-NAT. CB-NAT is available in the government setup, and TrueNet there are many studies telling TrueNat has got a little lower sensitivity than CBNat. So that may be the reason some of the cases it's not picking up. And TrueNat will be negative, TrueNat and CBNat will be negative if it is atypical tuberculosis, atypical mycobacteria. So here, unless we do a culture, yeah, culture is the gold standard. So that will be ideal. But here, CBNat was positive with bronchial alveolar lavage, so we have to consider it as M tuberculosis.
Renu, one doubt. If you have a 24-hour collection, is there a role for centrifuging it and looking at the supernatant?
No.
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 We used to do that for ascites. So it's not recommended
So this
anymore.
is thick, So there is no point, unless we do a concentration technique. That will be better. There are methods by which you can concentrate the sample.
Thank you. Betty, excellent presentation. Mohan, can we do this as a study? Or it's
may not be possible because of the
collection is going to be tough. We'll give them a big hand. Thank you.
Good morning. We are moving from a very excited topic to a miracle which happened in 2021 in a Department of Obstetrics. So we are just presenting that case. The heading given is From Coma to Come Back, myself Kurula with my madam, Patsy madam. So here the diagnosis which we have made for this patient is eclampsia, Curie status epilepticus with HELP syndrome and atypical press and the postpartum acute kidney injury. This is what we have made the diagnosis. And when we look into the history, she is a 30-year-old second gravida with previous cesarean. At 35 weeks, she was having hypertension. She was diagnosed to have severe preeclampsia with an IUGR baby. In the local hospital, she went there and her BP was 190, 110, and she was referred to nearby higher center. So in that center, they have noticed that while receiving into the hospital, she started to have eclampsia, and she was started on labetalol. They gave up to 220 milligram to control the hypertension, and they started on Maxulf, which was loading dose and maintenance dose was given. But they noticed the patient is not recovering back, and she is not becoming conscious. Her GCS was not improving, even waiting for 1 hour. So they decided to send her to believers. So they called us and they referred here. And when we received her in emergency, our emergency department, they did well with us, and her GCS was E1, V1, and M1, tachycardia, hypertension, and once we received her again in our emergency, she had another episode of seizure, and it was Curie like a status epilepticus. So our neurologist also came into the picture, and we saw the patient. It is 30 weeks cephalic, and there was no signs of abruption. So we decided by neurologists that we can intubate the patient because she was getting seizures frequently, and we discussed in our department and decided to go ahead with and do the cesarean section. On the way to the theater, immediately we intubated. On the way to the theater, we did a CT brain, which shows features of hypoxic ischemic encephalopathy changes in the CT. So by diagnosis of eclampsia, we started, the neurologist said it may be an HIE, press, and deep sinus thrombosis to be excluded. We did an emergency cesarean section. The baby was 1.4 kg, female baby, and the Apgar was 6 and 5, and the Leica was clear, and there was no features of abruption, and there was oozing overall. So we decided to put a drain, and we closed the abdomen, and she was transfused like 2 PRBCs, 3 fresh frozen plasma, 4 platelets, and 4 cryos were transfused to correct her DIC. You can see on the day of admission, creat was 0.7 and enzymes, liver enzymes were 1,224 and platelets were 94,000. So on the next day, June 7th, she was shifted to ICU and on admission, and still her BP was high and tachycardia was there, and the MRI done on the next day shows suggestive of this atypical press and no evidence of deep vein thrombosis, and the MRA was normal. The creatinine still was 0.6 and the enzymes dropped to 221 and platelet dropped to 54,000. But still she was intubated and ventilated. On third day, she was having a hemoglobin dropped, and for hypertension with nephro, neuro, we managed to give all these drugs. This is especially from the nephro side. They adjusted all the medicines to make the hypertension under control, and we started Piptas and Metro. So on the next day, that is day 4, we can see that again she's intubated. Her output was increased to 4,700. So it was a post-AT and diuretic phase, and creatinine was 3.5, and it came down to 2.95. That means it was an acute kidney injury which has happened. It was resolving, and the very important decision which the nephro and neuro made together was to give mannitol. And Dr. Arun said, if she goes into renal failure, we will dialyze. Let's make the patient live with mannitol. So the mannitol worked well, and she started to obey commands on the next day, and AK started to resolve. And we can see that by the 7th day, and we can see by the June 12th, we extubated the patient, and she was put on CPAP, and the acute kidney injury started to resolve, and she was still on high dose of antihypertensives. We can see the next few days after extubation, she was becoming better and better with all these drugs, and the creatinine, you can see it is coming down, and the patient became better. And by 14th day, you can see her MRI shows all resolving vasogenic edema and resolving subarachnoid hemorrhage, and the BP was controlled well, and the patient improved, and the patient was discharged with Licardia and Labetalol and other hematinics, which was used for this patient, and the patient is doing well actually. This is the miracle which happened due to the combined efforts of our neuro, nephro, and emergency team along with us. So we know that this combined effects of all these departments can save a mother which was from coma to come back. Thank you very much.
Actually, I wanted to highlight is, even though maternal mortality is lowest in the state of Kerala, hypertension in pregnancy ranks the second next to hemorrhage. And a lot of change has occurred to this title. Terminology has changed very frequently. Etiopathogenesis has changed, but the culprit is the placenta. So the moment the placenta comes out, she has to improve. So the key management is termination of pregnancy. But how well you strike the balance between termination of pregnancy, on one side you have the prematurity, and the other side you have the maternal morbidity and mortality. And here actually we could bring her from the edge of the life back to life because of the multidisciplinary team approach which happened here. And as we know, preeclampsia is a disease of multi-organ involvement. And I remember with thanks the nephrology department who took the bold step when we kept the fingers crossed whether we should give mannitol or not. They said, okay, we will dialyze and bring her out rather than compromising her life. And before I conclude, I want to say a few words. There were a few lives who got, which we couldn't bring, not over here, which we couldn't bring back, and which serves us to learn from their lessons through the audits and the case reports which we are doing over here. And thanks to the CAFOG and our Ministry of Health and Family Welfare, who periodically does the CRMD, that is the confidential require of maternal death, as well as the near-miss audits that is happening in the state as well as the national level. And it is those departed souls that teach us, and as well as these surviving people who teach us more about in improving our management. Thank you.
Any questions?
Good morning. It was an excellent presentation. Hypertension any time is bad. Now, in a mother who's a primey, and we have seen that the child has become an IUGR. So it means there has been placental insufficiency. Now, as a part of risk mitigation...
This disease, this presentation, it affected almost all organs. The CNS was affected, the placenta and the FGR was there, then hemopoietic system was affected, HELP was there, liver was affected, and it was the DIC and the HELP that pushed her to AKI.
Okay. Now, I want to know about risk mitigation. If this scenario happens again, how can we prevent it? Why is the stress on antenatal patient education?
Other than education, madam, now the Fetal Medicine Foundation has come up with good markers. In our 11 to 13 weeks, we have got ultrasound markers which will pick up the Doppler of uterine artery resistance, as well as we have serum markers like placental growth factor, as well as SFLT. And we have had an MOU with the fetal medicine department, has have an MOU with the Life Cell, and we are doing placental growth factor, not as a routine, but on request.
Thank you, madam. Thank you, Kurula sir, for the excellent presentation. Inviting Dr. Akash, Dr. Bobby.
Check. After two excellent talks, we are going into the third case of the day. This case is not commonly seen, but anybody who has encountered this case in emergency or the laboratory side will never forget this case. So we have a 64-year-old male who had recently been initiated on treatment for chronic lymphocytic leukemia. He had come to the ER on 30th of December 2024. His complaints was bluish discoloration and marbling of the skin, and blurring of vision, numbness of hands and feet, and generalized tiredness. So it started insidiously like 10 to 12 days back. Initially, he had bluish discoloration only of the tips of the extremity, and the symptoms worsened on washing of hands and feet and on exposure to cold. And he noticed that it used to get better on using a blanket and hot fermentation. So unfortunately, we don't have the original images, but then this is a representative image which very closely resembles the appearance of the patient on presentation. Multiple sampling attempts were done. Initial blood investigations could not be performed as all the samples which came were viscid and the test could not be run in autoanalyzers. So on presentation, he had a BP of 130/100. He was mildly tachypneic, tachycardic. SpO2 was 99% on room air, and he was afebrile. So since at the starting point we don't have any investigation, the patient was admitted to SICU after initial stabilization. We provided him with a warming blanket, and there also multiple sampling attempts were done. So this patient, we know the previous history and was sequentially on follow-up under our department. And in view of suspected hyperviscosity of the blood, he was planned for plasma exchange. So we consulted the Department of Nephrology. Dr. Arun suggested for plasmapheresis, and Dr. Arun helped us to proceed further. So his past history, he is a known case of chronic lymphocytic leukemia. He was on follow-up. On initial presentation, he presented to us with hemolytic anemia, and which was responsive to steroids. So it was a cold agglutinin disease, which was responding to steroids. He was also a known case of rheumatoid arthritis, hypothyroidism, and BPH. So these were the drugs which he was on at that time of presentation. He was started on with prednisolone for his autoimmune hemolytic anemia, for which he responded, and the steroids were brought down serially on a tapering basis. And on presentation, he was on 5 mg of prednisolone, methotrexate 10 mg weekly once, hydroxychloroquine for the management of his rheumatoid arthritis and other supportive treatments. So this was the initial blood picture at the time of presentation. There was features suggestive of autoimmune hemolytic anemia, RBCs showing agglutination, normocytic nomochromic RBCs with polychromatophilic cells. So this was the blood picture, shows significant RBC agglutination. This is captured at 20x magnification. And this is the same sample of the same patient when incubated at 37 degrees Celsius. We can see the agglutination getting better, suggesting that it is a cold agglutinin. So WBC picture showed marked leukocytosis, neutrophilia, lymphocytosis. There were atypical lymphocytes with nuclear atypia, and platelets. There was thrombocytosis. This was the picture where you can see the WBC, the atypical lymphocytes, the smudge cells you can see over here. So all these features at the initial presentation were suggestive of CLL. So the antibody test, the Coombs direct was 4+. He had a high LDH, suggestive hemolysis. Bilirubin again was an indirect predominant hyperbilirubinemia. Cold agglutinin titers were positive till 1:1024. And clinically relevant titers are above 1:64. Monospecific DCT, he was positive for C3D. And he was kept on sequential follow-up. And since on tapering the steroids, his autoimmune hemolytic anemia relapsed, he developed hyperviscosity. We initiated him on chemotherapy with rituximab, bendamustine. Cycle 1 was given on the 11th and 12th of December. And he presented to us on 30th of December. So when he presented to us with hyperviscosity, he underwent plasma exchange. In total of 5 cycles of plasma exchange, 4 cycles in the initial phase on 30th, 1st, 7th, and 10th. And cycle 2 of chemotherapy was initiated on 4th and 5th of January 2025. These are the graphs which plot the sequential LDH and bilirubin curves, which shows that there is a serial reduction in LDH and bilirubin after initiation of steroids, which shows that he was steroid responsive. And this was the cold agglutinin titers from the time of presentation in the early 2024. So he had a high cold agglutinin titer on presentation, 1:1024. Somewhere hovered to a maximum range of 2048, minimum of 128. And this was the IgM levels when he presented to us this time. So on presentation, we could not do any initial tests. So after the first episode of Plex, the first IgM levels was 2,874. So this, we can see that the IgM flare was happening, which was responding to plasmapheresis. And it dropped to 691 after the last Plex, which we discharged him. And then he again came back for the second cycle. So that time again he had raised IgM levels of 2,131. He underwent another Plex. Now the latest values are 625. So post-Plex there was complete resolution of symptoms, and presently he is doing well on follow-up. So the diagnosis of our case is IgM flare resulting in hyperviscosity in a patient with cold agglutinin syndrome, with a history of chronic lymphocytic leukemia, rheumatoid arthritis, hypothyroidism, and BPH. Over to Dr. Akash for discussion.
Hi, good morning. Just carry on from where Dr. Bobby had left off. So we already know this patient, a known case of CLL, who had a cold agglutinin disease, was on follow-up, which was steroid dependent. So cold agglutinin can be seen in infections, it can be seen in lymphoproliferative disorders. In our case, it was a CLL which presented in a similar manner. I'm just skipping through all of these. These cold agglutinin present 2 ways. One is the acrocyanosis that develops, and second is the hemolytic anemia that develops in such patients. So in our patient, when the patient came to us initially, so our initial suspicion was obviously that the cold agglutinin might be the reason for the symptoms. So for that, there are certain ways in which we go about this, and we keep the sample warmed at 37, 38 degrees Celsius and further run the test. We had done all of these things, and even post that, we were not able to run any of the investigations. Then we thought, what could be the reason that we were not able to run the investigation? Then we thought about this reason of hyperviscosity. So the patient is already a known case of IgM-CLL, and the IgM molecules are a larger molecule which causes higher hyperviscosity, and the patient present with a classical hyperviscosity syndrome, which had there was mucosal bleed, visual abnormalities, and neurological abnormalities in this patient. And so the laboratory studies include doing a serum viscosity, which is difficult to do it here. And when the patient presented to us, we were not able to run any of the investigations because of the high suspicion. And with liaison with the nephrology department, we started the patient on plasmapheresis. And after the first cycle of plasmapheresis itself, the patient had clinical improvement. As well, we were able to run the other investigations as well. The important thing here to highlight is that the patient was on treatment, and post-treatment there was worsening of these symptoms. There was something called an IgM flare. So this is seen in patients who get rituximab. there may be worsening of the symptoms, an increase in IgM level, which happens after the first cycle, and that will cause a hyperviscosity and worsening of symptoms. And the only way to treat that is plasmapheresis at that particular point. And this is generally seen in the first 2 cycles, post which we don't see it. So the patient is already through his 2nd month, and we don't expect any more worsening to happen after this. But we are obviously liaising with the nephrology department if that is required. We are prepared for that as well. Thank you.
I will just say a very interesting thing about this case. Hematology department contacted nephrology and told, we have a patient in the emergency department. We don't have any blood investigations, 0 blood investigations. The moment the blood is taken out from the body, it gets clotted. It is not moving. It cannot be transported to the lab. Even the lab people cannot do. So we think this is hyperviscosity and clotted agglutination. We don't have anything to prove. Please do a plasmapheresis. We just trusted them. We did what they asked. So the ICU people were very surprised. The patient is coming to the ICU with no lab reports, anything. It is just a clinical diagnosis from the hematology side. And we did a very invasive procedure. Plasmapheresis is not just a simple thing. We did a plasmapheresis just by believing their words that the blood is very thick.
I think that is kudos to the multidisciplinary team that we have here, that we trust each other's expertise so much. And I think Akash brilliantly picked it up and as soon as it came to the emergency, because without anything, they also don't know where to refer. So we had a lead because he had a cold hemagglutinin disease earlier. So that lead, he worked on it and we were able to get the diagnosis. And this is a brilliant, very rare phenomenon. And in hematology, I think we are very blessed to see almost all spectrum of cases and thankful to the support from the multidisciplinary team that we have here. Thanks, Arun.
Thank you.
Thank you, Dr. Akash and Dr. Bobby for the presentation. So we have 2 special guests from Karlstad University, Mr. Mansoor and Mr. Jesper. I invite you to be on stage, please. So they are from Karlstad University and doing their final year in nursing there. So they will be with us for 8 weeks. I invite George Andy sir to present them with a flower bouquet. Thank you.
Just want to tell you all that the Karlstad University collaboration is working out very well. They're looking at a lot of research because in Europe, they want the association with a third world country. And fortunately, they've chosen us. So if you have ideas and if you want to do things, please come forward. And while they're here and they can take back the good news. But they keep coming. They'll be coming in May. So any ideas that you have, because they will write to the Erasmus Foundation, and then you can do research with them. Thank you very much.
Thank you so much.
Take our wishes back with you when you go. 2 more quick things. You know, Dr. John Valiath was the man for us in terms of fitness and running and all that. Suddenly realized we have somebody who will give him competition. This is the Medical Education Unit Head, Community Medicine star. His name is Liaquat Rupesh Johnson. Can we see him? Can you run here, please? He went to Bombay and was in the top 50. Congratulations from all of us. Well done. So students, he's the man to go to. And finally, I'm very delighted. See, we've been looking for the academic program in radiology, and I'm sure many of you gain a lot because radiology is at the center of a lot of beautiful things that happen. And we found somebody, she's feeling shy. Her name is Anita Susan Paul. She's a senior consultant in radiodiagnosis. She did all her studies in CMC Ludhiana, and then she did her fellowship in the Royal College of Radiology and is here with us. She's an expert on MRIs and CT scans and all that. So any problem you have, Anita, can we see you? Welcome. So this was a beautiful exercise. It took a lot of effort from a new team, and I want to thank, no, I won't thank Arun. And I want to thank Arun and Abel for the thought, the idea, and I hope we'll have, at least once a month, we'll have these clinical snippets so that we enjoy learning a little more and understanding a little more. Thank you to all three teams for the fantastic presentations. Thank you all for coming.